I would like to continue with our next lecturer, who is Dr. Pushparajah, who is a clinical senior lecturer at King's College, as well as a consultant pediatric cardiologist in London. And he will be talking to us about the new developments in fetal echo and fetal cardiac MRI. Dr. Pushparajah.
Lovely. Thank you, everyone, for the opportunity to share with you some of our experience here. At the Evelina, we work across Guy's and St Thomas's, King's College Hospital, and have an affiliation with King's College London. I must say I was totally in awe of the last speaker's demonstration of imaging. And I would like to just add to that and build to the narrative and focus specifically on some of the cardiac applications. I've included some fetal echocardiography, but a lot of my focus here really will be on fetal cardiac imaging, which is where my expertise really lies in. I've spoken to my colleagues in the fetal department, and I said to them, what do you find useful that you do in day-to-day clinical practice now that you didn't do a little while ago? And one of the things they shared with me was, in the past, we all have in our cupboards the 2D grayscale color Doppler pulse Doppler for assessment of the fetus. And that works very well as a screening tool. But in earlier gestations, there are some newer modalities, like as you can see here with superb microvascular imaging, where you can actually really try and define the smaller structures of the heart. And this is some examples here that I can show you. And the advantage with this sort of imaging modality is the fact that you can look at low velocity blood and you can see some of the really smaller structures, which is really more relevant to the fetal cardiologist. And so on the example on the left here, you've got a normal arch, and you can see the ductal arch and the native aortic arch really very clearly, because what you're doing is you're suppressing some of the tissue motion to extract flow signals from the smaller vessels. And in this patient here, you can see the aorta arising from the anterior right ventricle in a patient with ventricular arterial discordance or transposition. So that's something you can apply in your day-to-day practice already. This is some really quite a nice summary, if anyone was interested, written by Rabbi Chewy in Berlin, who's talking about 3D and 4D imaging. And effectively, we're talking about spatiotemporal image construction or stick acquisition, which has been around for about 15 years. But in the past, because you had a single line of your matrix array probe and you'd have a motor and you're basically doing sweeps to produce a 3D volume, which is very susceptible to artifact. But the point I want to make with this slide is that the technology and the matrix arrays have improved. So your acquisitions now are 2 to 3 seconds potentially. And there are a lot of ways that we can interrogate the data that you've acquired. And really, there's sort of technical image processing leaps that have happened in parallel with the matrix array improvements. So you can start to see, normal heart, pericardial effusion here, and critical aortic stenosis. And then if you apply color as well, you can start to appreciate with a bit more depth some of the spatial relationships of ventricular arterial connections in the patients. So quite useful, but it really depends on the hands of the clinicians. The other thing that we're starting to look at beyond function, we're getting a bit more sophisticated in our thinking and progressing the specialty. And we're looking at strain, what is happening at the level of the ventricle. And it's very easy to do. I have to say it is angle dependent, and there are good papers out there that you can have a look at, because if you're really doing this, your imaging plane needs to be vertical to the plane of the long axis of the ventricle. And so, but we are starting to see some really interesting publications. We've seen in our group patients with confirmed coarctation have reduced LV deformation and strain. And then another group have reported now the global longitudinal strain of the left ventricle is reduced in patients with pulmonary arterial intact ventricular septum. And it's even worse in those with RV-dependent coronary circulation. So again, we're trying to add another string to our bow in terms of getting more sophisticated in our ability to more accurately predict some of the worst outcomes. Ventricular strains being done in our group recently. We've got something that's about to be published. And we're starting to look at atrial strain. And of course, if you look in adult literature, there's a lot of data out there about atrial strain. So maybe this is an interesting area that may develop even further. So in terms of what I do, we do fetal imaging for the heart, and actually it's working with expert radiologists like the previous speaker. They've been imaging the thorax, the brain, and all the other bits of the fetus for ages. But cardiology, or the cardiac imaging, has always fallen behind. And because we have this really mobile fetus without ECG gating, now remember, all your postnatal imaging is based on having ECG gating. We're not able to do that in the fetus. You've also got very small vessels, as you'll see here from my slide. So it becomes very challenging in terms of motion and spatial resolution. So I wanted to take this challenge. The previous speaker spoke to you about single shot imaging, and I wanted to explain that to you. If you watch this hummingbird, the wings are beating pretty fast, and if you've got a really terrible camera, you're going to just get this sort of blurred image. But if you've got a very high shutter speed, you can actually try and just capture the hummingbird when it's still. But of course, so if you take a single shot, you can rapidly acquire an image, and you can eliminate some parts of the motion. But the problem you have, of course, is this fetus doesn't just flap its wings, it's moving up and down. So if this hummingbird was going up and down as well, you're going to have a bit of a problem. And so with single shot imaging, you can get views like this if you're lucky with the aortic arch, and here you can see an RV aneurysm. But when we look back at our first cohort of patients, when we started to do this, we were finding that we were getting data loss in up to 14% of patients. Now, if you put a mother in the scanner for cardiac indication, it's quite big, it's quite expensive. It's difficult for the mother, so you want to guarantee you're going to get something useful. And I think for us, 15% data loss was unacceptable. And if you look more recently as well, in Shanghai, they've published their experience of using 2D imaging. And actually, it was largely normal hearts where they couldn't really see the anatomy very well on ultrasound, but they're still having a high proportion of incomplete diagnosis when you scan at very high numbers. So for us, we needed to move away from 2D imaging. We needed to build on 3D reconstruction to try and eliminate the effect of motion. And this is where Mary Rutherford and her team in the Center for the Developing Brain were miles ahead, and they were using these motion reconstruction algorithms for the brain. Of course, the brain's in the cranium and it doesn't beat and it doesn't need an ECG to gate, but we applied it in our cardiac imaging, and you can see if you stitch together all of the images and mask the region of interest, you can actually create 3D whole heart volumes, which I'll show you recently. But with any new technology, validation is key. And so we validated this in a cohort of patients against ultrasound, and you can see the very tight observer correlation between the two imaging modalities. And so we felt very confident then that we could accurately measure things as well as see things. And so we start to reconstruct, and most of our images are in the second trimester. We really scan at about 30 to 34 weeks because that just works in our clinical workflow. There is less motion at that trimester. We haven't done earlier gestation most of the time. And very late gestation doesn't actually help anyone in terms of decision making. So here you can see a right arch mirror image branching, and here's a patient with a double aortic arch. And what's interesting as well is in the very same patient, emphasizing what the previous speaker said, postnatal correlation is absolutely key, because otherwise we could be scanning nonsense, reporting stuff that's totally inaccurate. But we always correlate with postnatal imaging, and you can see the left arch here has become atratic. And so you could easily think that this is a right arch with mirror image branching, but actually this patient had a double aortic arch. The other thing, of course, is things like cardiac tumors, and this fetus had a fibroma, and you can see the extent of the fibroma. But what's important is that we were able to delineate the potential obstructive lesion nature of that on some of the outflow tracts. And here, despite the size of the lesion, the RVOT was actually relatively patent. We also talk, all of what we do is multimodality. The MRI augments what we do with ultrasound. And this fetus from Dr. Vigneswaran, my colleague, concerned about a really restrictive atrial septum on ultrasound. And of course, we're using more sophisticated things in simple, but I would like to say a little sophisticated in that we give maternal hyperoxygenation. So you give the mother oxygen, and that should cross the placental bed, cause pulmonary vasodilatation and increase pulmonary blood flow. Of course, if you have a restrictive atrial septum, you wouldn't be able to increase the pulmonary blood flow. And so you can use the pulsatility index fairly reliably in ultrasound to see how the patients are. We add to that and we can do an MRI scan, and this is where it gets interesting. So we do the 3D whole heart reconstruction, and this is a patient with TAPVD, where all of the veins go through a vertical vein and it's compressed. So there's this supracardiac TAPVD is obstructed. We can map out the flow through the whole fetal circulation, and here you can see the pulmonary blood flow is diminished, and then we correlate that with the fetal lung MRI, in this case shows pulmonary lymphangiectasia. So before the baby is even born, we know this carries a very poor prognosis, and it informs the counselling. Again, the correlate of this patient with dilated pulmonary arteries, massive pulmonary arteries in tetralogy of fallow-absent pulmonary valve. What you can see, of course, is the fact that it creates airway compression with fluid trapping effectively, and you can get regions of the lung that are super bright because water is bright on MR. And postnatally, you can see the correlate there, these areas of hyperinflation. And this patient really struggled and needed ventilatory support for several months and was in hospital for several months. So you can prognosticate. So even if you don't have the ability to do a complex heart MRI, as a cardiologist, if you see this, send the patient to your radiologist to at least look at the lungs for you, because it'll help guide your decision making. So what do? We largely do things like vascular ring assessments, suspected coarctation, hypoplastic left heart, pulmonary veins, and assessment of pulmonary arteries. There are things like pulmonary atresia, where you're not sure if they're disconnected or how the connections are, and that's really quite important. And so we're really running a clinical service, and we're scanning in excess of 100 patients a year. Blood flow measurement is the next challenge, and the key people who pioneered this is Mike Seed's group in Toronto, working with Chris McGowan, and really they effectively do post-hoc gating, because remember we have the challenge of not being able to gate with ECG, and the group in Germany, Fabian Cording and the group, they've commercialized a product now which allows you to apply a Doppler ultrasound and extract an R wave that you can then use. So effectively, you just use that and you plug in your normal images. So the group in Hanover are really leading on this. Cine imaging is something everyone's trying to do. Ultrasound shows things really nicely, but if you can do cine imaging through the whole heart, wouldn't that be nice? And so the group in Lund, this is Costas Harris, working with Anthony Alteris, have worked very hard on this self-gated sort of problem, but motion is still an issue. And so for us, even you can do all of this, you still have an issue with motion. So we've really focused on, in our group, on how you conquer motion. And so what we do is we scan the fetal heart like this, and we take orthogonal planes. So this is the same features. You're scanning in one plane, and then another orthogonal plane, that's coronal, and then axial. And then what we do is that we can calculate a cardiac phase for every time using some post-processing. And then you can actually generate a 3D whole heart image like this. It requires quite a lot of computational time at the moment. So it's actually, it's not really point of care treatment at all. It takes several hours, but all of that can be accelerated. So within that 3D cine data, we're also starting to extract flow data. So now it gets really exciting. You've got 4D flow data within a fetal heart. Now that opens up all sorts of doors. So the problem we have, of course, is we're only scanning it so like 30 weeks, 34 weeks. But you guys as fetal cardiologists, you want earlier information. So our reconstruction worked for the brain, and of course the heart moves around. And so we're now reorientating the whole fetus, and therefore with some new algorithms, and this is hot off the press, really. These guys, Maria Deprez and Elena Uz, they work with us in School of Biomedical Engineering, and they've resolved some of those issues. And this is the same reconstruction algorithm that we use to produce those beautiful images at later gestation. But this is a 23-week fetus with a lot more motion, and we can polish it up to look like this. And so this is where we're going to be focusing on. A lot of insights in physiology, but this is at a research level, and we haven't got time to discuss it. But if you look at publications by Mike Seed in Toronto, this is where all the action's at, and it's really looking at the placental brain and cardiac axis in the fetus, and that has implications for all the interventions that we do. So in the near future, I think this is where we're going. We can get comprehensive fetal MRI, anatomy, function, flow, very much akin to what you get in postnatal life, and I think it's there. It's there. It just needs to be at a point where we can all use it without having a whole team of researchers. The other thing I wanted to focus on, of course, is the machine learning neural networks. We've got ultrasound data, we've got patient factors, and we've got other imaging modalities. And I think MR's key in that. And then we can really try and have a bit more precision medicine, biometry, improved screening. This is Bernard Kynes and Tom Day working on in our group again, looking at some artificial intelligence. And you can see here that the computer, it's early stages, right? But this is a left ventricle here, and you can see that the computer can detect very clearly hypoplastic left heart. Of course, this is not hard. A human being can detect hypoplastic left heart, but you have to start somewhere. And I think the ability to apply machine learning in these sort of contexts is really exciting. So I'm going to stop there with something a bit futuristic, but I would just like to thank all the people in my group. And we have the ability to really accelerate a lot of these developments, working with the clinicians as well as the biomedical engineers. There is a working group within SCMR for fetal and cardiac imaging. It's a really good special interest group, and if you're interested, please get in touch with me. Thank you. In fact, there's the slide of it.
That, I think, is an excellent lecture. We continue with the third speaker.